Good afternoon, and welcome to SHM's Practice Management Webinar Series. For 2020, this series brings together experts from all over the country to cover the most important operational topics around the COVID-19 pandemic. In light of current circumstances, this live webinar and subsequent recording have been made temporarily accessible to the public at no cost. Resources such as these are only made possible by member dollars. If you find today's webinar valuable, we kindly ask that you please consider joining SHM to ensure continual access to the content you need most. CME credit is available exclusively to SHM members through our online learning portal after registering for a free account. Without further ado, I will now turn things over to Shika Alcala, Chief Operating Officer at OptiMed Hospitalist, who will be moderating today's discussion. Thank you for joining us and enjoy the webinar.
Thank you, Luke, for that introduction. Hi, everybody. My name is Shika Alcala. I actually go by Kika. A lot of people know me by that name. So if you're confused when you see Shika, that's my real name. So, I would like to thank everybody who joined us today for this webinar. The topic, as you can see, is the hospital staffing challenges during COVID-19 pandemic. I have these experts here with me today so we can talk to you about all the challenges that our hospitals are facing across the nation, especially during this COVID pandemic. Number one, can my panelists see my slides? If you can I get a thumbs up if you can see my slides? Perfect, thank you. We got to make sure. And also I want to mention, unfortunately, we do have some technical difficulties with one of our panelists, Crystal. She can see us. Can you hear us, Crystal?
I can hear you. Can you hear me?
Yes.
Yes.
There it is.
All right. We're in business.
That's awesome. Whatever Luke did that worked. Thank you so much. Okay, so we're good to go. Oh my God, I feel so much relief right now.
Sorry. Challenges.
Hey, it happens. In the age of pandemic, everything goes, right? So this is, like I said, it's a panel discussion. We do have some already prepared questions. However, I do invite all the attendees to please, if you have any questions for our panelists, if you have any questions you want to send right now or during the discussion at any point that you have a question, go to your little sidebar here on your go-to webinar and click on the question tab right here, and it's a toggle that goes down and you can type in your question. I will be able to see your question and go through it, kind of filter it, make sure it's an appropriate question, and I will ask it of our panelists. So this is how you can ask the questions throughout this webinar, even at the end. So we are open-ended questions throughout the webinar. Please feel free to send in questions at any time, and we'll make sure that all of your questions are answered. And also I wanted to tell everybody and let them know that the Society of Hospital Medicine has this excellent resource for anything COVID related right now in the hospital medicine. And also this webinar specifically is going to be recorded and uploaded to this excellent resource, and all the previous recordings and webinars can be found here. And there's hundreds and thousands of excellent resources for coronavirus and the COVID pandemic. So please utilize that. It's very helpful information. A lot of work hours went to it. So I would love for everybody to kind of use this as a guide too. And kind of give you a brief introduction. My name is Shika. Like I said, I go by Kika. I will be the moderator of this webinar. I will make sure that all the panelists have adequate time to answer all the questions. I want this to be an organic flow of conversation, like conversation amongst friends. So I will not be that type of moderator that barks questions at people. I don't ever want to do that. So it's going to be a very organic flow, hopefully. Like Luke said, I am the Chief Operating Officer of a small to medium-sized hospitalist group located in Davidson, North Carolina. We work in a rural area in North Carolina. I am also a member of the Ethics Committee at Iredell Memorial Hospital in Statesville, North Carolina. I am a board member of the Healthcare Management and Healthcare Master's Program Board of Advisor at Appalachian State University in North Carolina, and that's also where I went to school. I am the president-elect of the Society of Hospital Medicine Charlotte Metro Area chapter here in Charlotte, North Carolina. And I'm also a member of the Society of Hospital Medicine Practice Management Committee. And that's how kind of where this webinar kind of came to fruition, is the discussion from the Practice Management Committee members. And we realized that this is a very important topic for a lot of hospitals right now across the nation. And that's why we wanted to have this discussion today. So after this, I'm going to leave it up to my panelists to introduce themselves to you guys. And we will start with Dr. Ajjan. Take the mic.
Yeah, hello, good afternoon. Thank you for inviting me. I'm happy to be with you. Thank you, Sheikha, for the introduction and for also managing all of us to be in this wonderful meeting. My name is Mahdi Ajjan. I'm internal medicine hospitalist. I'm the medical director of the hospitalist group in my hospital. Also, I am the CEO of Optimed. We are a company that serve nursing homes and hospitals, providing hospitalist providers and nurse practitioners and PAs. And also we manage our practices in these facilities. I am the chief of staff in my hospital. I also serve most recently as a member of COVID-19 Crisis Management Task Force, and I'll be happy to share what we learned so far. And of course, there is a lot to learn from the panelists and from everybody as the crisis, unfortunately, is still unfolding. Thank you.
Thank you, Dr. Ajjan. Our next panelist is Crystal. I don't ever want to butcher your last name. How do you say your last name?
It's Quayle.
Quayle. Okay. I was like, I know it's Quayle, but I didn't want to say it wrong, and then like, embarrass myself in front of all these wonderful people that joined. But I think I already did. So thank you, Crystal Quayle.
No worries. So yes, thank you very much for being our moderator. And my name is Crystal Quayle. I am representing a large academic hospital in the Northeast at UMass Memorial Medical Center. And I am the lead NP for a group of approximately 27 APPs in our hospital medicine division, as well as we work in collaboration with about 70 hospital medicine attendings as well. And during the COVID crisis, really the peak for us, we had a lot of moving parts going on, which I will speak to, which was a bit challenging. But we all had the same goal during COVID, which was nice. I also am a member of the SHM Practice Management Committee, and I have during COVID at UMass, I had developed guidelines for rapid response and resuscitation during the COVID pandemic.
Thank you, Crystal. And our next panelist is Jason Santoro.
Everyone, thanks, Kika. So again, my name is Jason Santoro. I'm the Director of Business Development for Health Carousel, and we're a medical staffing organization that recruits from allied, nursing, advanced practice providers, and physicians. My responsibility is I oversee strategic initiatives for the physician and advanced practice division. And within it, we have three unique brands. We have Onyx MD, based in Dallas, Texas. Next Locums, based in Dayton, Ohio. And Lucidity Direct, which is at our headquarters in Cincinnati, Ohio. But our services on the physician advanced practice side range from permanent placement and basic locums to project-based supplemental staffing, where we ensure coverage for significant staffing gaps. And Lucidity is a little unique. It's an online platform designed for providers seeking an automated self-service approach to their job search. But personally, on me, I have over 20 years experience in business development consulting, and I've performed multiple roles within the medical staffing industry, and I have relationships with many hospitals and hospitalist groups throughout the U.S., including Optimed. And I'm an active member of SHM as well, and I attend as many events as possible. Unfortunately, not San Diego this year due to the pandemic.
And San Diego's always been my favorite.
I know. next year.
Hopefully next year. Is it next year Vegas? Are we going to go to Vegas next year? I can't remember. Is it Vegas or Orlando? Whichever it is ongoing, anyways.
we met in Vegas, Kika, if you remember.
I know, yeah, we did meet in Vegas. Yeah, we sure did. That was fun.
So I guess the last thing, if you haven't heard from my accent already, I'm born and raised and currently live in the greater Boston area. But I look forward to this discussion and answer any questions you may have from my perspective on the staffing side. Thank you.
Okay. Thank you, guys. Thank you, panelists. So just to let everybody know, so we do have 3 major topics that we would like to cover in this webinar. The first one is challenges with recruiting, challenges with retention, and then challenges with being efficient in a hospitalist program. And those are the 3 topics that we're going to discuss. So any of the attendees, if you have any questions about those right now, you can please feel free to ask your questions to us. But we already actually do have some preset questions when we first started this webinar. So I will start with our first topic, which is recruiting challenges in the middle of COVID pandemic. And I'm sure this has affected, every industry, not only the healthcare industry, but from our perspective in the hospitals world, it takes more of an effort to recruit for physicians, nurse practitioners, and PAs. We tend to like to have our physicians fly over, or our providers generally come fly and tour the hospital and do things like that. But of course, in this pandemic, it has not been feasible. So I think that would be the easiest question to ask to all of our panelists is, what recruiting challenges has your organization faced during this pandemic? And maybe I would like to, I'm biased, so I would like to start with my CEO, Dr. Ajan, if you would like to answer that question.
Thank you, Sheikha, and I'll be happy to hear also from Jason and Crystal about their unique problems during that time. The challenges, as you might expect, providers, when they receive the news about that COVID is here, and at that time, March 18, it was the first order, stay home order, March 18, and there were thousands of cases, but then rapidly they were going up. At that time, all the hospitals, they went into crisis mode, and the providers received that as mixed feeling. So first, immediately they understand that they are front lines in the fight against COVID, and that's actually boosted morale. They wanted to help, they wanted to treat patients and help the community during that time. At the same time, there was the fear that all of us we had, and the fear from 2 folds. One is to get the disease itself. Family member might get the disease. You as a provider, the hospitalist provider, you can get the disease and then you take it home with you. And if you have elderly parents living with you, or that's the fear that the providers shared with us actually in the first few days. At the same time, there was another fear, the fear of chaos. So the chaos that COVID-19 can bring to any organization. And at that time in March, if you remember, the images were coming from Italy. It actually created some kind of anxiety in nursing staff, provider staff. So we felt at that time we can try to control the disruptive nature of the pandemic and disease by forming the task force. So the fear from the disease was the biggest challenge that we had.
Okay, thank you, Dr. Ajan. Jason, do you want to chime in?
Yeah, so to your point, Kika, one of the biggest challenges we had were, hiring in a traditional manner where a provider would come on site to meet, the staff and get a feel for the hospital and the community. And thankfully for Zoom and the technology we're using today, I've seen some clients try to keep the process moving forward through Zoom, but it is really difficult when somebody is moving to maybe another state without, having to really see that. So I've seen it slow down to a point where it almost wasn't happening. For example, with the travel restrictions, if I had a candidate in Texas that, had an interview in New York, the travel restrictions would make that provider have to quarantine for 14 days. So but we've seen some of it really stall from that perspective. But I do see it picking up now more. But certainly 6 months ago was a real challenge and I think a different priority.
Yeah, I agree with you on that. Crystal, do you have anything to add?
Sure. So coming from a large academic institution, we did have a unique opportunity where we had recruitment essentially internally. And what I mean by that is we had a lot of our outpatient things in clinics closed. We had procedures canceled. We had PCP offices that, that all fell under the UMass Healthcare umbrella come together and want to help. So there was a lot of mixed emotions. There was fear about contracting the disease, bringing it home to your family members. We've had people have children, like babies, during this pandemic, and they have elder family members that they're living with at home. So there's that piece. There was the enthusiasm from so many people outside of our division, like, what can I do to help? I'm willing. My clinic is closed. Where can you put me? So kind of recruiting and doing a super fast onboarding process with those type of people. And then the division ourselves, as you know, in many other places, took the brunt of it, right? So the hospitalists and the ED and the ICUs, but really coming together literally on a day-to-day basis where we are changing things, one thing from the morning to the next night, to try to adapt to everything that's happening, to also handle a surge, to also onboard those people that are coming from other places. We call them redeployed people, where they were coming from. We also graduated the medical students early that were heading into their intern year, so we could get a few weeks extra out of them, to do little things like calling family members because we couldn't have any visitors in the hospital. So we literally had an outpouring of people, and it was really challenging for us to take care of the COVID patients frontline, but also figure out how to plug in all these other little pieces into the puzzle in the safest manner during this pandemic.
Gotcha. So you touched on a really good subject about credentialing process, which is, we know, I should be nice and say things like, it is the most cumbersome process that any hospitalist has to go through. So what was that like for you guys during the COVID pandemic when there was an immediate need for staffing? How did you kind of jump through hoops to make sure that your provider is fully credentialed to start working? So what was that like? Maybe I'll start on Crystal, if you want to touch on that, since you kind of gave me the idea for that question.
Sure. So, like I said, for the most part, people were already employees of our institution. However, it was getting them credentialed quickly in hospital medicine or inpatient or working that. So the state of Massachusetts actually waived a lot of the meth controlled substance registration, physician, supervisor that they needed to have in order to be able to quickly recruit these people. And we had people credentialed under emergency credentialing. It expired, I think sometime in either end of June or July, once we got through the peak. And then we're playing a little bit of catch up from that standpoint, but we were able to do emergency credentialing for people, and it went fairly well. We did have some hiccups, but it wasn't as bad as it could have been.
Right, and I can speak to that on the locum side of things. We had clients that were trying to develop contingency plans in case, they saw the volumes, and then we had, clients that were seeing the volumes and needed staff immediately. And, one client that comes to mind in New Jersey was able to capitalize off of the state license waivers. And because of that, there was an influx of providers that from New York that will live nearby, that because of that license waiver were able to submit their application and get approved within 24 hours. and the credentialing piece was done really quick. So I know that was certainly helpful, certainly chaotic, and I know what I'm dealing with now when I'm talking to my clients is that, they're trying to develop a contingency plan for a potential second wave where we can be more organized and have that contingency bench of providers already lined up so that, we can function more effectively.
Yeah, and I echo what Crystal and Jason said, that the hospital, our hospital, they were ready for emergency credentialing in case we need that. So that partnership between us and the hospital became very vital during the crisis. So forming the task force, the COVID-19 task force helped in that to prepare what should we do in case we need more providers. So many of the restrictions were lifted when the pandemic crisis started.
So that's I think I also want to add, the restrictions were lifted. The state lifted the restrictions. Hospitals are doing emergency credentialing and things like that. However, I don't think I've heard anything from the insurance side of things. So since this is a practice management webinar, I always have to bring in the money part to it. So hospitals did this, states did this, but I don't think I've seen anything on the insurance side, meaning like Medicare, Medicaid, insurance companies, where maybe they would help out and try to speed up that process for the providers that are coming in, joining this new organization or locuming for a new organization. Any of you have heard or seen anything of that sort? Because I feel like everything happened on the facility side, the state side, but then nothing happened on the insurance side of things. No.
Personally, I have not. I don't know.
And that's the sad reality about it.
I can comment on this. I mean, I'm not aware that there was special credentialing process with Medicare or the insurance. But however, part of the incentive that we received from HHS, part of it is to address that as well. In case of loss of revenue, the SBA and the HHS, they try to help practices. So they were expected loss of revenue from multiple reasons, and maybe we can explore that in coming questions. And for that reason, they addressed it through the provider relief fund and what have you. Other than that, I'm not aware of a special insurance credentialing during the time of crisis.
This question is from me actually to Jason. When you guys were assisting your clients at highly affected states, kind of like New York and Florida and Texas, did you have to give incentive pay to your providers or emergency pay for your locum staffing agency? And what was the impact on your company?
Right, so that's a really good question, Kika, because it fluctuated. It was very unpredictable. So, for example, in the metro area of New York, there were just so many providers that were looking for help that, the rates were a lot lower than what we've seen traditionally. But we had responded to a crisis opportunity in Florida, and it's a less accessible state. So with providers that were coming in, we're asking for, hazard pay and higher rates to be exposed in that situation. So it was all over the map and very untraditional. So if that answers your question.
Crystal, did you guys do that at your organizations? Because you had a pretty high impact on where you are, no? What was that like?
So, like I said, we had a lot of help from people who were redeployed. So where a person might have worked 40 hours in the clinic, their 40 hours were now met in the inpatient setting. There was, challenges about, should we pay people that are working in the actual COVID units more money? Or, we also had a field hospital. What about those people? And, it was challenging because we did not really incentivize it specifically, because everybody was internal, or for the most part, everybody was internal. So we had people that we were able to redeploy. that being said, we do have moonlighting rates anyways, because we have shifts that we need to fill in general pre-COVID. So those were paid out as normal.
So I can,
So it's a mix.
Yeah, I can comment to similar to Crystal. We relied on our deployed providers, and that helped a lot. First, they were happy to contribute their time and effort, but at the same time, also they were able to recruit for us from their friends from other hospitals. So the schedule for hospitalists, usually it's 7 on, 7 off, and it allows some flexibility. So they were able to call their friends in case we need help. And through that internal management of our providers, actually, we were able to have recruitment with the same rate without the need to increase the rate.
Yeah, and I feel like, this is a crisis. Nobody's going to come in and be like, people genuinely wanted to help. Nobody was like, I will help you if you give me X amount of money to help you. That wouldn't, I'd imagine that wouldn't sound good. So I'm glad that happened, because I've heard of stories like that in New York where people are like, we're just here to help. This is not about the money. We just want to help. We realize we're in the middle of pandemic. So that was very heartening to hear about. Jason, did you guys have any unique ways that you had to change your typical locum contracts when it comes to kind of staffing, your clients and things like that? You want to talk a little bit about that?
Absolutely. So, when COVID started, obviously there was a low census, and we had clients and, multiple specialties that had, our providers signed, and there wasn't a need for them. So a lot of shifts were canceled within the range of our contract that would, represent a breach. But, the position that we saw it was, we wanted to be partners with our clients, and we didn't want to hold any of them to, the term. So, for example, the average locum assignment, there's a 30-day cancellation policy. So, and that's held both on the provider side and on the client side. But we saw a large volume of shifts being canceled. So, we didn't have or issue any recourse to our clients because of that, because obviously it was a tough situation. So another thing we did as we were getting crisis opportunities, when we're talking to our clients, there would be a spike in volume and a hospital would be overpopulated, but they didn't know how long they were going to be overpopulated. So as we're trying to build a team to go down and relieve the hospital and relieve the perm staff, we couldn't just build out and contract the providers for the standard term. So we were, we had to accommodate the ebb and flow of the crisis, really. And we had more of a crisis cancellation term where it was, mutually agreed upon with both sides that it would fluctuate and it may not be, you couldn't hang your hat on 30 days of shifts if they were canceled. And that's how we handled our part. I don't know if all agencies did it that way, but for the most part, I think that they did.
Okay. Chris, I want to ask you this question. So given that you are in a large system, you said that you deployed a lot of people. Did you typically, in some scenarios, when you needed the help, were you allowing like APPs, nurse practitioners, and PAs to go do a service that typically is done by a physician? Did you guys make changes to those things?
Not specifically, because we do work together quite collaboratively. So,
okay.
Really, it's a formality that our attendings need to co-sign our notes, and we can't admit under our name. So we do have a very highly variable skill level of APPs, ranging from new grad to over 10 years. That being said, we functioned in a more horizontal model, and what I mean by that is even on the teaching teams, typically you have your hierarchy where the attending is the supervisor, and then you have your resident, your intern, your med students, or you have one attending with 2 APPs who kind of all see their own patients. So what we did during this pandemic was kind of break it down a little more horizontally. So you would have your team leader who would kind of sprinkle in your patients. And the nice part is that this really hit in March and April and May, which was the latter end of the teaching year. So, you know, we really took that to our advantage because your interns were just about getting to their second year, so they could function a little bit, I don't want to say more independently, but more horizontally as opposed to the hierarchy. As for the APP hospitalists that we had, the hospital medicine trained ones, not the redeployed ones, but the hospital medicine trained ones, typically, and the attendings were the ones that were covering the actual COVID units, and that we took more of an ICU approach, meaning this is what we have for the day. You see this many, you see this many, you see this many. So, so that changed a little bit. I would say it was a lot more collaborative because we were also on a unit, and as hospitalists, unless you're geographical, you don't really have a home. So that was actually a nice thing that we had during COVID.
Okay, thank you for that. So if you guys are okay with it, I would like to move to the second topic. I know we discussed like a bunch of other things in this topic, but it's fine. To the topic of retention. And of course, I will start with the question of what challenges has your organization faced in terms of trying to retain your current talent during the COVID pandemic? And I will maybe start with Crystal.
Okay, so this is a tough one. You know, you have people coming or going not related to COVID for whatever reasons that are happening in their personal life, and we had a couple of that happen. But then retention within your hospitalist division is challenging. We were very lucky in that we did not have many sick people that needed to have time off because of exposure or testing for exposure. I would say probably the testing for possible exposure was really a hindrance because we weren't sure how to do that initially. So people would, you know, potentially have an exposure, and then even defining what an exposure was so variable, right? So, you know, people would be out for 72 hours waiting, or 5 days waiting for tests to come back. You know, so other people are trying to fill those holes. And I think during COVID, especially at the beginning, we had that adrenaline to get us through. And then it was just, you know, and it still is, we're seeing effects of COVID, obviously. But it is, the adrenaline wore off and people got burnt out. And it is a traumatic experience that everybody has been through, you know, and we really feel it. So that retention is something I'm very nervous about for all people and providers who really took the brunt of this, whether, you know, they're in an institution together or if they're even locum providers or, you know, whatever it might be. We've all been through something traumatic together, and it's, you know, we're still seeing the effects. Who knows how long we'll see the effects. So the retention has been a challenging thing. I'm not, you know, I'm struggling myself with things and ideas to think outside of the box to boost morale, to keep people at least engaged, you know, because everybody's so tired. So that's a big challenge about this. But really, the challenge, one of the challenges was when people get exposed and the testing and how to handle that and who needs to be out, who can work, can you work if you're asymptomatic, if you're wearing a mask, you know, that kind of stuff. We're much better at that now, but it was very challenging during the peak of the pandemic.
So,
thank you, Crystal. Dr. Arjan?
Yeah, I can talk to that as well. So what happened in our group, like Crystal said, the adrenaline was high, everybody motivated, they want to get, however, they wanted to make sure that we as admins and managers are taking care of them. So meaning the PPE, protective equipment are there and available for everybody. It meaning that when they need testing, it's available for them if they feel like they might have been exposed to the virus. So for that reason, that's where the anxiety came from. And we were really, in the beginning, we were anxious that some people, they will feel that now they are not protected enough and they will leave the job because of that. And this will include providers and also the admin staff. So the admin staff for us, right away, if we feel like they can work from home, we send them from home, and if they can do that, they can work from home on their in their offices with technology and everything. So we did that without a question. If somebody needs to go for paperwork, they can go one time, manage the paperwork, manage whatever needed, and go back to their home office or physical office outside the hospital. So this is the admin step. We made sure that we have a line of communication. In the beginning, it was a daily email to all the people involved in our hospitalist group. And that daily email had in it PPE, had in it testing procedures, admission and triage procedure, had in it everything. And then we encouraged people to ask questions. So we had a lot of questions in the beginning saying that, how do we know if we admit somebody and we don't know if they have COVID or not, and they have minor symptoms? Are we going to be exposed to that patient? Shouldn't we wear N95 for every patient we see? Where are we in N95? Do we have enough of them? What's going to happen when our hospital is going to have 30 patients or 50 patients of COVID positive? So they had all kinds of questions, and we were able to run scenarios with our team and with anybody who wants to ask. So I think that daily communication helped a lot in our retention and just lowering down the anxiety for people. One of the challenges with retention, also big challenge, when the kids they were unable to go to school and they had to go home and to have school at home through the technology. So it forced some parents to stay at home, and this was challenging for some of our admin staff as well. So we provided flexibility in order to navigate that challenge, and actually so far it looks like it worked fine. We didn't have any resignation actually in our, I mean, Kika knows that. We didn't have any resignation due to COVID.
Yeah, and to piggyback on what Dr. Ajahn was saying, like I love that you're also talking about, not only the hospitalists, but also the admin staff that are supporting the hospitalists. We didn't want to put our hospitalists at risk and having the admin staff go to the hospital, because that only will spread, they might be cross-contamination or spread. Even like we did have a scare for one of our admins that was in the hospital, and, he realized that like, I'm not feeling well, and, we realized like, what, it's an unnecessary risk that we would put our providers through if we have our admin person in the office. If they can do their job from home, let them stay at home and do their job. There's no reason for this unnecessary risk. And that's that one thing we did for our organizations. If you can work from home, stay at home. But, as Dr. Ajahn said, we had challenges with, for myself personally, I was gone on maternity leave, and I feels like I'm still on my maternity leave. This is the longest maternity leave in history because I haven't left it yet. But you gotta ask a husband, ask mother-in-law, whoever that can help, just so we can support our providers at the hospital as best as we can. So it's been challenging, and it has not been easy, and I can attest for everybody that's going through this right now. But luckily, having an organization that believes in work safety, workplace safety, employee safety, it definitely helps a lot. So, Jason, do you want to add anything?
Yeah, I mean, so from the client side, my perception is that, I haven't seen massive fallout, but I've seen a slowdown in hospitals, going out to bid for, new hospitalist groups. I've had clients that were staffed but did see, a burden in the beginning, and they brought in supplemental staffing to relieve, the perm staff from a mental health perspective and from a perception perspective. But to your point, even, outside of the hospital, my organization did a lot to, have employees work from home, and, we did the best we could retaining our staff here. Luckily, we didn't lay anybody off, so that was a good sign too.
And also, we always try to focus on hospitalists, but also, like, I want to mention, like, we do have hospitalists that are SNFists that work in the SNF, And, as everybody knows right now, the skilled assisted living facilities and assisted living facilities are struggling major struggle with exposures in their nursing homes. So one thing that we did is provide telemedicine, which was the easiest thing to do. If, for example, there was a mass exposure in one nursing home where everybody has to be tested, we don't want to put our provider at risk. So we provide them the option to do telemedicine until they kind of test everybody in that building or transfer the people that are positive to keep our providers safe. And we unfortunately for us, and I'm sure for other organizations, we did have providers that were exposed. They did have to stay at home until they got better. The government came with these really great alternatives and plans for COVID leave, FMLA leave, and things like that. So that helped us a lot. And also for those who don't know, once an employee or a provider is out because of COVID, there are special tax breaks that you can implement in your payroll that you can get tax credit back for that employee that was affected for COVID. So that helped us tremendously, and making sure that, we're providing that kind of like network and security for our providers to let them know, like, hey, like, we understand it's very special times and some of you are going to get sick, but we do have these special like leaves for COVID that will help you get better. And then also as an employer, help us keep you. Because, as everybody knows, when a provider leaves or is not able of working, it is very costly for the employer to find their replacement and then pay for someone that's not producing. But luckily, there are these safety nets that the government created that help us. And then actually, I do have a question kind of related to that one from the audience. It says, I work with a community hospitalist group. There are 7 hospitalists scheduled per day. What are some schedule adaptation/contingency plan you suggest in case a scheduled staff member must stay home due to becoming ill with COVID/flu? Dr. John, do you want to start answering that question?
Yeah, sure, of course. So we have to be careful about burnout. So you don't want to be short-staffed during COVID, and this is actually an important topic. I'm glad that we are bringing this. So as all of us experienced, or majority of us, except hospitals in New York and New Jersey. So when in March COVID started, our census dropped. I mean, in many hospitals, our census dropped because hospitals started to cancel elective surgeries. They did a lot of workaround so they can maximize their capacity in case there is a surge or many patients coming through ER and they need ICU. So when our census dropped, I mean, the question comes to mind: shall we short staff? Shall we send people home and maybe we can cut down on staff? So we were very careful with that because we know that we are frontline providers, and we didn't want to do that. So we didn't actually send anybody home. And we know that taking care of COVID patients require more work, require more time to take care of patients with COVID. You have to wear the PPE, you have to wear your mask, go into the negative pressure room. So it takes more time. So we didn't have to let people go home. Even the census was half. We kept all the staff ready for in case of crisis. So what happens if you have the existing staff, seven hospitalists, one of them, I mean, God forbid, get sick or sent home? And this is something actually we thought about it, and we put a scenario, we planned for it. What's going to happen? So what we did several things. If you remember, Kika, we sent right away an announcement. We want volunteers to sign themselves up as a backup. And so, many people signed up for every day as a backup, just in case of somebody will get sick. And these people, typically, they are not working that day, so they are off. So they signed up as a backup in case somebody somebody will get fever because of exposure or what have you. So we have a list of people signing up as a backup. The second thing, I advise leaders to also try to medical directors to shorten the number of their shifts. So if a medical director typically are doing 12 shifts clinical, they need to short down to 7. And of course, they can stay in the hospital just to lead the group and everything. But this way, it gives them some buffer just in case they need to step in and help the group. So you have to create some capacity, extra capacity in order emergency. At the same time, you need to have excellent relationship with Jason. So just in case you get short-staffed, you call Jason so you can get more people. Something we did also very rewarding is that we didn't say no to any help. So we had multiple cardiologists, multiple gastroenterologists. They said we are board certified in medicine or we know medicine. We are happy to help you in case you become short-staffed. We are happy to step in and become one of your hospitalists. And actually, I started collecting all their names, all their phone numbers, just in case of crisis. So everybody, we can put everybody on schedule. Another solution also, and this is we do it in hospital medicine. If you see our group, usually 7 rounders, there are people who are coming in the middle of the shift. They do admission or they do support for heavy time admission. So you can always use the people who are designated for admission as a rounder in case of emergency. So you can rearrange the daily tasks for the group. I mean, I see these are the things that we put scenarios for, and luckily, I mean, we didn't have to use many of them, but it was good to have a plan in place.
Knock on wood.
Crystal, do you want to add to that?
Sure. So we do have a backup system in place already because we have such a large group. However, it is not perfect. And, we do the same type of structure where we would kind of email blast out, sometimes even text group, hey, we have this happening. Anybody willing to pick up? We foresee this happening for X amount of time, because if somebody truly is out, has symptoms, and is actually COVID positive, they might be out for 4 weeks because, they're out for that 14 days or whatever it might be, but they still have a cough, and a cough is one of the symptoms that you can't come to work with, so it's really trying to recruit from your pools and then also stay in touch with that person to see what their status is and be sensitive about it because they're sick, but then you also have to have an understanding of when they might return, so you can have staffing planning, but also reaching out to the other subspecialties, PCPs, people that you can pluck from here or there. It's really, really helpful.
Thank you. Jason?
Yeah, so I'm working with clients now on contingency plans. So we're getting docs and advanced practice providers credentialed to, as a backup in case there's a situation where their initial plans are not working. But I have noticed that with the second wave, or even with the initial peak of COVID, that hospitals and hospitalist groups have been able to create very large pools of local candidates, to Dr. Jean's point, to help backfill in those situations, and it's probably put you even in a stronger situation. But we do have some clients that are credentialing docs just in case as a backup.
Mm-hmm.
Okay, there's I don't know if it's a question, it's more of a statement, but I'm excited about it because it's somebody from the UAE, Mohammed El-Wah. I'm sorry. I know, yeah. So he's saying, during difficult situations, the most important is the flexibility and teamwork. Although we were in need for hospitalists and we were using deployed physicians like GI or cardiology, few hospitalists were deployed to help the intensivists. The few exposed hospitals were helping from home to triage calls, other admin support, and that was the Cleveland Clinic in Abu Dhabi, UAE. Isn't that exciting? So that's a good point about having people at home taking phone calls.
Yes.
So that's pretty exciting.
Yeah, so I would like to maximize, basically say yes to anybody willing to help. Say yes, and keep them in the loop. So keep them in your email, mass email, telling them what's happening.
Mm-hmm.
So you need them to step in and help.
So there's a question from one of my favorite people. He's asking, do you not think the hospital should offer on-site COVID-19 testing for the providers instead sending them to clinics to be checked?
Ooh, that's a tough one.
So for us in our hospital, we do have that. So in case somebody needs testing, any of our employees, they got tested in the hospital. But it's up to every organization.
Yeah.
Yes, it's one hospital. It's up to every organization. It's a logistic question. I mean, the bottom line, you want to be safe and efficient and fast. So you want that person to be tested as soon as possible with a good, reasonable turnaround for the test result. So the faster, the better. I mean, and we've seen varying degrees. Some lab, outsourced lab, they give you the result the same day. Some people, it takes like 2 to 3 days to come back with the result. So I will advise facilities to choose a way that is fastest. But for our main hospital, any of our employees, they were testing in-house, and we got the result within 2 hours.
Yeah, and actually, this is from personal experience. A lot of urgent care clinics, like for-profit urgent care clinics, they do provide rapid COVID testing that only takes 20 minutes. So that's just FYI for people who would like to know. It's much faster than going to like a CVS or Walgreens or any pharmacy that you're in your area. Urgent care clinics typically do it fast, and insurance covers it with only that urgent care copay. So just FYI. So I think we can hop in. We have 5 minutes left, so I want to definitely make sure that we cover the efficiency part of our discussion, and I think I will maybe hand it over to Crystal and to discuss efficiency challenges during COVID pandemic. So,
okay, so rapid fire. This is a little bit of a busy slide, but really it was figuring out your phenotypes, right? Your provider types, and figuring out where you can put them. So you have your traditional hospitalists, your NPs and PAs. You have your medicine learners, so resident, intern, medical students. Then you have subspecialty attendings, moonlighters, and locums that, you know, all work within hospital medicine or Department of Medicine, or at least inpatient, right? So really when you are making decisions on who to put where, you take a look at what the need is. So here at our institution, we would have COVID-specific units. So we could put the hospitalists in those units, and then the acute care floors, we could take kind of a mix of, you know, somebody in medicine, right? So we had pulmonologists taking care of gen med patients, same thing with renal people, or nephrologists taking care of gen med patients. And then there was a DCU field center, and, you know, the thought process was, all right, that's kind of a lesser acute COVID-ish type of unit, maybe outpatient, or, you know, but you're going to be able to recognize when somebody decompensates quickly. So, so it's really figuring out who your phenotypes are and then where you can put them. Like the PCPs, they don't work inpatient, so we did a really rapid onboarding process, made a whole bunch of documents, how to discharge, how to admit, how to do a med rec, and then there were at least one hospitalist on every other unit to kind of help guide those people, which takes time, but still it's knowing what your skills are and where you can best fit them for optimizing patient safety. And then same thing when you're looking at.
No, go ahead, sorry.
So then the demand, right? When you're looking at COVID unit versus non-COVID unit, what we were finding is the COVID unit, the ratios of provider to patient was a lot smaller because they're such heavy lifts. You have to gown up, you have to spend, you know, a certain amount of time in there, or try not to spend that much time in there. And they're very sick, have lots of things going on, so they're heavier lifts. So the staffing ratios would be lower for COVID. And then for non-COVID units, you have your redeployed people from other divisions or outpatients who you probably have to lower the patient amount or the number of patients that they're seeing strictly because they're functioning in an inpatient setting, which they're not used to. So again, just figuring out where your skills are and how to best deploy them and matching the demand of the patient care.
Absolutely. And so you really touched a little bit, and I like that you talked about it, the linear versus the hierarchical kind of like staffing thing. Did you find like, I bet it was a relief for a lot of the medical schools. Like, yes, I get to graduate early and I'm already doing the job that I wanted to. Did you, like, was there any kind of like a layer of like nervousness or anxiety with that, with like seasoned providers? So can you talk a little bit about that?
Yes. And, you know, it's challenging because it takes time to teach somebody or show somebody the ropes, no matter what you're doing, right? No matter what level you are. And, you know, you have these newly graduated students that are just so gung-ho, and you're like, okay, where's the best place I can put you without doing harm, but also being efficient? So, you know, things that are really important that we might not have time to do, that, you know, medication reconciliation, calling facilities to get paperwork, you know, getting most forms that have already been filled out from somewhere. So things like that. And then they would see probably a patient here or there. They wouldn't see as many patients as the interns or the other folks, but they were definitely very, very helpful.
That's good. Dr. Ajahn, what things that you did for your hospitals in terms of trying to be more efficient in this pandemic?
Yes, so similar to what Crystal said, that we dedicated from the beginning, we dedicated a COVID team. We call them COVID captains. So we had in one hospital, we have 5 rounders. 2 of them, they were COVID providers, 1 for the ICU and 1 for the floor COVID patients. And this is where you, Crystal also touched base on that. Basically, you put like the doctor in one floor and nurse practitioner in another floor. So they become a team of a doctor and nurse practitioner, so they can work throughout the day, even if they transfer somebody from the ICU to the floor. And we have very well-trained nurse practitioner PA. So it doesn't matter, actually. They were in the ICU and the doctor on the floor, or vice versa. So sometimes the doctor in ICU, sometimes the nurse practitioner is in the ICU. We do have intensivists, of course, on the team. So every COVID patients, they have the infectious disease intensivist and the hospitalist are among the caregivers, the providers taking care of the patient. So typically they stay, the COVID captain, they stay the whole 7 days, and then they transition to another COVID captain. And we ask people to volunteer into this task. So we filled the whole schedule from the beginning up to like 3 months with COVID captains. And they were instrumental in efficiency, in knowledge. They were sending us reports every day, what they learned about the disease. So we really maximize the benefit of having a dedicated team for COVID treatment. So there was a COVID unit on the floor. The ICU was divided into half. Half of the ICU became COVID patients, the other half for everybody else. So that dedicated unit was important as well. We maximized from the beginning the number of negative pressure rooms. We even transformed one regular floor to a step down unit, just in case we need more ICU beds. We might be able to, on the floor, we do an ICU bed in the floor. And the challenge was to have trained ICU nurses. We were in high demand for ICU nurses. So to go to the floor and staff that extra beds for ICU. So we did that in the beginning, actually, in the first few weeks. And we were able to achieve that by a daily meeting in the morning. So we have our COVID task force meeting in the morning, deciding, taking questions from all the providers over the day, and then answer them in the morning. And so these are the things that we worked on in our system.
Thank you. I want to make sure I ask this question before our time runs out. It's an audience question. How did you manage census slump with existing employed providers? If you have worked RVU-based compensation model, did you make any changes to work RVU assignments? Thank you.
So for my part, we didn't change any.
We didn't change anything. We did not want to mess with people's compensation, even though it was slump time. But we did take measures into ensuring that I believe, Dr. Ajahn, you want to talk a little bit about this, reaching out to the surgeons and to take admissions for them and things like that, so we kind of like mitigate that slump that we had. Talk a little bit about that.
Yeah, just 1 minute. I know that we're exceeding the time, but 1 minute about when the census dropped, and if it drops in the future, what we did. How do you increase your census right away to compensate for the loss of revenue? So that was an opportunity to, for me, reached out to the surgeons and the surgicalist group and told them that we are universal admitters. We can take care of your patients. We admit them, and of course, we'll consult you. We will co-manage with you. But that was the time to make any delayed projects happen right now to increase your census. And they receive it very well, usually. I mean, they love our hospitalists meeting with them, and they are very motivated to manage our patients with them right away. So this is what we did, is we increased the number of people that we can admit under our service. And we provide good quality that way to our patients as well.
Yeah, and also like for us as an organization, because we did receive HHS money, we didn't want to furlough employees or terminate people because we had that like slowness in our census. So we had to keep everybody in order to be able to have those kind of grants that were given to us from the government and the loans that we took out. So that's one thing our organization did. Because I know there's another question that was asking the same thing. How did you handle like staffing down or like for the slump down census? The answer to that question is like we did, and we kept everybody that we can keep.
Mm-hmm.
So, and Chris, I'm assuming you guys didn't have that problem. So you guys had surges rather than slump down.
Yes, we did. And that, I was going to say that happened organically with us, because here we have other subspecialties that admit for themselves, but most of the patients were coming in as PUIs, persons under investigation for COVID, and that would come to us. So, you know, we were admitting sickle cell crisis, acute loops, things like that, that normally it would go right to BMT or something. So that did happen organically towards us.
Yeah, and one thing I mention, sorry, Sheikha. Also, primary care physicians who are practicing traditional medicine, this is the right time to see if they want to see patients in the office, and if they want to transition their patients in the hospital into the hospitalist group. So this is the right time to address it if they are ready to make that change.
Yep. Mm-hmm.
And Jason, what about your clients that kind of experienced a decreased census? What did they do?
Yeah, to echo Dr. Jean and Crystal, we saw a lot of specialists, doing work on the front lines, and unfortunately, we did see a lot of providers on furlough and things like that. So hopefully, we get to the second wave okay, and things get back to normal. So.
Awesome. So since we're running out on, what are you guys' expectation for the future, and if you think that there will be a vaccine for this?
Well, let's hope so. Either way, we're all hoping to not have a second surge, but trying to prepare for it anyways. And I think the most important piece is to remember that, we are all reaching for the same goal in taking care of patients, getting through this pandemic, whatever that looks like on the other side, and working together. And really, through the thick of it, what I find talking to other leaders across places is it's that daily communication that really keeps the division going, right? Because you're really changing things almost on a daily basis.
I agree with you on that, Crystal. Dr. Jean?
Yes, I mean, nobody can predict the future. I can say there is a vaccine in phase 3 with multiple companies. For how long the vaccine will be effective, we don't know yet. So when it's ready, all of us will receive the vaccine. In the meantime, we just do what we can right now. We have to take care of each other. I mean, we have to take care of each other. This is very important. One thing that's important in taking care of each other is the daily communication. Check on your colleagues, check on your admin staff, on managers and everything. And with that, actually, we are stronger and we can get over any crisis that happens. I will emphasize also the importance of training, including ICU skills. People need to be confident during this time. Many hospitals are stepping into ICU for the first time. So training should continue for ICU, and also to keep your schedule balanced and and recruit as usual. You can look at the SHM State of Hospital Medicine data right now. It has about compensation, schedule, benefits, be competitive, so you can recruit the best. Your core team are the most important people, the core team that you can depend on them during this time.
Nathan, prediction for the future, what do you think?
Well, look, from the patient perspective, the hospital census is down because of, a lot of it has to do with perception. So, and of course, the news cycles have a lot to influence that. So it'll be interesting to see, how things proceed as we get further along in the election. I don't know if that's okay to say, but I also think that people are smarter now.
Okay, we'll allow it.
People have much better habits wearing masks, so I don't know if that would predict a milder flu season, but yeah, I think getting that perception from the patient's mindset that it's okay to go back, it would be key.
Thank you guys so much for your time. I appreciate all the wisdom and information you instilled on us today. And thank you for all those who attended and asking the questions. Those are some really great questions, and I'm happy that I was able to get through all of them. If any of you have any questions for our panelists, this slide has their contact information. Please save it, screenshot it, what have you, because I have to move on really quickly and kind of wrap this presentation. We're over the time. And please, I have to let you know that ACHM is doing their best in trying to providing these excellent webinars on various different topics. And the next one coming up is maintaining work safe place during COVID. It's going to be Tuesday, October 27th, 3 to 4. So thank you all for your time. Appreciate it. And we will be concluding this webinar. Thank you. Bye.
Thanks, everyone. Stay safe.